Welcome everybody, and thank you for having me today, and lovely to be in such esteemed company with Professor Demopoulos here and Professor Joshua and Professor Ho. My part of the talk is a very easy part of the talk in one sense, and I suspect you know quite a bit about this already, but I'll just set the scene a little bit, and I'll try and get through this fairly quickly so we get to our other guest speakers. Just to set the scene in Australia, the last set of full statistics we have from the Australian government is 2009, and 1,500 new cases of myeloma were diagnosed in Australia in that year. And that's about 1.3% of all new cancers and about 10 to 15% of all blood cancers, so it's relatively rare. It's more common in men than in women, and the average age of diagnosis is around 69, 70 years of age. Interestingly, over the last 25 years, the statistics seem to show a slight increase in the incidence of myeloma, and that's a little debated, but will be interesting to see. People of African descent have myeloma more commonly than Caucasians, and the Asian population have it quite rarely, so that's of interest too. Many of the risk factors for developing myeloma are things that we actually can't control. So increasing age, being male, obesity seems to have a role if you're of African background, and less likely if you're of Asian background, but exposure to toxins such as benzenes and ionising radiation are also risk factors. Having a first-degree relative with myeloma is a risk factor, and the presence of a monoclonal gammopathy of uncertain significance, or MGUS, as it's easier to say, is also a risk, and I'll talk a little bit about that later, but Professor Demopoulos has already mentioned that as well. So just to put you very simply into the picture, this is our blood system, and our blood stem cells make red blood cells and our platelet cells, and in the box there you see the white blood cells, and they're important for immunity. Now, down the bottom there is a plasma cell, and this plasma cell is derived from a B lymphocyte, and the plasma cell is what becomes malignant or cancerous and causes myeloma. Plasma cells live in the bone marrow, and there's a picture of some plasma cells there. And so when people develop myeloma, the bone marrow and the bones are very commonly involved. This is a schematic diagram, but our normal plasma cells are very, very important. Our white blood cells detect bugs in our system normally, and they instruct our plasma cells to make antibody. So the Y-shaped structures there are our antibodies, and they attach to bacteria and other organisms and instruct our immune system to destroy them. Now, antibodies are important in myeloma too, and antibodies are made up of both heavy chains in the blue and light chains in the red. And some patients with myeloma make the whole antibody, and some patients make the light chains. So in the normal situation, we have lots of plasma cells. They're all slightly different, and they all produce different antibodies to attack different bacteria and different organisms or infections that we might get. In myeloma, one clone of those plasma cells grows excessively and takes over, and in most cases produces a protein, a myeloma protein or a myeloma antibody in excessive amounts. And as I said, it can be the whole antibody, or for some people it is just the light chains. Now, I just wanted to get some terminology out of the road because it can be very confusing. So you'll hear me talk about antibodies and protein. Antibodies are proteins, so that term is used a bit interchangeably. And you'll hear people call these monoclonal antibodies, monoclonal immunoglobulins, paraproteins or M proteins. It means the same thing. It's all interchangeable, so just to stop any confusion there. So what causes the clinical presentation in myeloma? Well, the first thing is having too many plasma cells, and this causes a number of problems. It causes holes in the bones. Now, not all patients get every aspect of this, but just as an overview. So holes in the bones, and it also, due to some hormonal changes in the bone, can cause osteoporosis or osteopenia, thinning of the bone. The myeloma cells can take over the bone marrow and cause suppression of our normal blood cells, and the main way we see that is with anemia, with reduced red blood cells. can also cause very high calcium levels in the blood, and calcium levels do make people feel quite unwell and quite sick. And also it suppresses the normal levels of our normal antibodies to fight infections, so some patients will present with increased infections. The other aspect is too much antibody or too many light chains, too much protein. And this causes what we call hyperviscosity if it gets very high in the blood, where the blood gets very thick and can often cause patients to feel quite lethargic or even confused. The light chains are particularly toxic to the kidneys, so if a person makes excessive light chains, they can develop renal failure. And sometimes the antibodies attack the nerves and cause neuropathy, which is damage to the nerves. It's often noticed in the feet, particularly as numbness or pain. Now, in the last slide I had some red letters, and this is to indicate what we call, and again I'm just helping you with some terminology here, end organ damage. So when doctors are looking to diagnose myeloma, one of the important things to decide on whether treatment is required is whether there's what we call end organ damage. And doctors and medical students learn this by remembering the word CRAB, which stands for high calcium, renal failure, anaemia and bony lesions. So, the presenting symptoms for myeloma most commonly are bone pain felt in the back or ribs, bones that maybe break easily, so with a minor fall or a minor trauma, a broken bone develops, frequent infections. Tiredness is very common, and this can be caused by anemia or kidney failure, and easy bruising or bleeding due to suppression of the bone marrow. Less commonly, people can develop confusion with that very thick blood, or with high calcium can develop confusion or constipation or abdominal pain. And as I mentioned before, neuropathy can cause numb and painful feet. But some people will be relatively asymptomatic and not realise that they have a problem, and it may be found incidentally when they're having tests for some other medical condition. So Professor Demopoulos has actually mentioned some of these terms, but I'll just explain them very briefly. This is three very closely related entities that are very similar, and it's very important that the doctor works out which condition the patient has, because the first two, MGUS and smouldering myeloma, do not require treatment, but symptomatic or active myeloma does require treatment. All of them have the protein in the blood or the urine. All of them have clonal plasma cells in the bone marrow. And in the case of the first two, there's no end organ damage, so those CRAB symptoms that I just was mentioning are not there. But in myeloma, there is end organ damage, and this is the group active myeloma that needs treatment. So in the testing to diagnose patients, it's very important that we categorise patients into these groups, because only the last group needs treatment. So the standard investigations are to make the diagnosis of myeloma, to see if the patient needs treatment by demonstrating end organ damage. And some of the tests we do actually help the doctor choose which treatment they might like to treat you with. So here's a list. Now, the doctors may do a lot of other tests to check your general health, but these are the tests we do specifically for the myeloma. So to run through them very quickly, a full blood count to check if people are anaemic, and biochemistry, looking for that high calcium or to check that the kidneys are functioning normally. And then we look for the protein. This is done by a test called a serum EPG. And you'll see on the side there, a bit hard to point with the mouse, apologies, but there's a band here. This is what normal people's protein in their blood looks like. And the second band, band B beside it, has an extra big blob of protein or antibody at the bottom, and that's the monoclonal protein or antibody. And graphically, number C is a normal graph of people's proteins, and D is from a patient with myeloma, and they've got this big spike of protein there. We look for the protein in the urine as well, as some people predominantly we see the protein in the urine, and we look for normal levels of antibodies to see if patients are at risk of infection. And we also do a couple of tests called the beta-2 microglobulin and LDH, which does help the doctor to know a little bit how aggressive it is and how quickly treatment might be required. Bone marrow biopsy is a very important part of the diagnosis, to look for those clonal plasma cells in excess in the bone marrow. And on the specimen, we also do genetic studies, and with some of the newer agents, we know that some of the new drugs that we have to use in myeloma work better with certain genetic abnormalities that are in the myeloma. So that's very important information for the doctor to have. We also look at the bones, and plain x-rays in the form of a skeletal survey show holes in the bones and show up quite easily, but sometimes we do MRI scans, and in this case, this person where the arrow is has a collapsed vertebrae due to myeloma that's pressing on the spinal cord, and that's very important that we detect that and treat that very early. There are other scans such as CT scans or PET scanning that can be done in certain situations, but these two are the most common. So with that, I'd just like to thank you for your time and hand over to our other guests. Thanks.